Hi there. How's the new CFO? I see the place hasn't fallen apart without me yet. I'm here to get coffee with an old friend. I work right down the street. I'm on the faculty at the university. An adjunct, actually. I keep trying to retire, but I just can't seem to stop working. No, just picking her up. Why? What's up? Yes, that could be from any number of things. Where is it showing up? Don't I know it? Between lower state and federal revenues, high labor and liability costs, not to mention rising costs for regulatory compliance, it's a huge challenge to be a CFO nowadays. I have to be honest, I don't miss the stress. True. What are you doing to research it? Of course. Why don't you email me and we can set up a time to meet? That's where I would start too. And you know, Michael is great. He always goes the extra mile. I really miss working with him. Perfect. And don't worry, you'll figure it out. Remember, have all your ducks aligned before you approach the CEO with a solution. Meredith likes it when you have the answer ready before she's even heard the problem. That's a very diplomatic way to put it. You'll do well here. If you need any help anytime, please let me know.
I like what you've done with the office. Very nice. I chatted with Cheryl earlier today. Great. Did she go on a rant about healthcare reform? I mean, I know she's right. All the wrong things are negatively impacting our outlook, but she really can't go on about it. Oh yeah, I have it right here. I ran it comparing this year to last year. It's not what we expected, though. Here's the thing. The total number of outpatient visits was actually up. And not only that, volume seems to have increased across the board. So it doesn't appear that volume is the problem. I hope you don't mind, but when the volume report didn't show any issues, I went ahead and did a collections and accounts receivable analysis. But just on 1 month, not on a quarter. Didn't have time. There are no discrepancies there, no outliers or big accounts that are not caught up. Sometimes we have a problem with Green Shield, but not in this quarter. The answer is going to come from, yes, part of the billing cycle. It's possible that charges are not being generated or that there's some sort of problem in claims. For that matter, it could even be a computer glitch. I really don't know what to look at next. Yes, please do. You know, it's not just your job on the line for these numbers. Hey, it distracts me from worrying about the economy in general, so that's actually a good thing. I'll wait to hear from you on what you want me to do next. Thanks. I'll see you soon.
Hi there, good to see you again. Of course. Ask what? Did you already look at the volume report? Okay. A 15% reduction over one quarter is sort of unprecedented. I couldn't stop thinking about it last night. Do you have any ideas about it? I think it's in the billing cycle too, and I have an idea about how to look for it. But first, I want to back up a bit and make sure we're on the same page. We'll see soon enough if I'm right. Okay, stop me if you have any questions. If you already know that documentation isn't the issue, we have to look at the data around charge capture. Even though the data is collected for clinical reasons, that same data goes to billing. The clinical information is assigned a diagnosis and procedure code, and that links to the DRG, the diagnosis-related group assignment. Most of our healthcare payers provide payment based on those codes. Right. I mean, we're oversimplifying it a bit, but that's the flow. So that's how we capture the charges for billing. The billing department posts charges through charge slips. Ours are automated, of course, so there's no room for data entry errors there. But here's where it gets tricky. Our charge master lists all the items for which the hospital has established prices, and it's a very long list, something like 15,000 entries. I forget exactly. Good. So you're with me so far. So now the information from the medical record is captured and the items compared to the charge master, and this must flow into the actual claim. Let's say you have more than one claims person who is sort of new. The processor is editing a claim and makes an error, either in properly identifying the patient or is posting charge slips manually because they're afraid of the new system. If there's a problem, either capturing the correct charge from the master or making a data entry error, you can run into significant issues. Oh, it could get even worse if it's unchecked. I know because it happened right before I became CFO. I watched my predecessor struggle with the same issues, but that loss was closer to 19%. It took 2 quarters to rectify the problem and catch up. I would start with the revenue and usage summary and compare this year to last year. That would show you the quantity of items billed by charge code and payer and break out the volumes by inpatient and outpatient areas. Definitely. I want to know how it works out. I'll see you soon.
Oh, hi there. I was just making a copy for you so we could look at it together. Well, I found something that might explain it. Earlier, we had just looked at total volume for outpatient, as that was a simple solution. But we didn't look at volume in terms of procedures. But as soon as you mentioned the report, it came to me. So I started by looking at types of procedures for any numbers that were widely different. I found that drug administration codes were way off. The codes for both injectable and infusible drugs were well below prior year levels. Well, check this out. The important discrepancy is this. Even though the codes used for those procedures were down, according to the usage summary, the number of those drugs used in the hospital had actually increased. Yes, exactly. I'm almost positive it's administrative coding errors. If it was me, I would look through the reports and see if there are any other possibilities before I talk to Meredith. I'll give you a copy with my notes on it. Let me know if you have any questions. That's fine. I love tracking down revenue problems.
Hello, Meredith Lynn speaking. I'm good, just busy. What can I do for you? Oh, really? What is it? You're saying that miscoding those two items caused a 15% revenue reduction? That doesn't sound right. How did you arrive at that conclusion? Okay, I see. How did you get from there to the drug code issues? It's a good theory, and it may be part of the problem, but I don't think it accounts for the whole amount. Did you run the numbers or just look at the outliers? You know, I would prefer that you come to me with facts rather than theories. In this case, I don't think the bundled payments we get for inpatients or APC outpatients would be affected by a failure to document the procedure, and bundled payments account for a majority of the revenue. Okay, but please don't get back to me until it's solved. Thank you.
Hi there, how's it going? What do you mean? I thought you figured out the problem. Oh, don't let her attitude bother you. She's so busy, she sometimes forgets to show her human side. So, did she say why she disagreed? It looks like this may be very similar to the same problem we had nearly 5 years ago. Oh, right, the bundled payments. We'll have to go a little deeper into the coding then. Well, let's talk about the different claim categories, see if we can figure it out together. Maybe we were just looking in the wrong places. So, there are two basic categories of claims. The UB04s, which cover claims for both inpatient and outpatient, and the CMS 1500 for physician and professional claims. And then HIPAA requires that we use both diagnosis and procedure codes. We use HCPCS codes for procedure reporting for outpatient services and also for physicians. Yes, but there's more. The HCPCS codes are usually included in the charge master. If it's not in the charge master, data entry clerks have to be sure that the appropriate charge codes are used at each entry. That's one possibility, but we have to narrow it down. Claims are usually sent to a clearinghouse where they are grouped together and then sent to the appropriate payer. Meredith may be talking about Medicare bundle payments. See, Medicare groups payments together using algorithms, including diagnosis-related groups, which we talked about earlier, and APCs. APCs are ambulatory patient claims. We have to use these codes for every machine or procedure used to care for a Medicare or Medicaid patient. So you see, there's a lot of room for error. Don't worry, we'll figure it out together. It will just take some time. For example, on the claims, the wrong procedure could be listed, or the right procedure, but no code listed for a product that coincides with the procedure, like blood transfusion, but no blood product code. I still think the same reports will reveal the answer. We were just looking in the wrong places. Also, I think if you see the actual claims forms and see how codes are used, look for patterns there that might do it. I'll send you the forms tonight. Of course. I love figuring this stuff out. I actually miss it sometimes, especially when it's not my job on the line.
Oh, hi there. You're still up, I see. Yeah, and I still have the reports handy. Let me bring them up on my end while you fill me in on what's been going on. Okay, so it sounds like it's an issue related to bundled claims or bundled payments for Medicare patients. Did she narrow it down at all? We have to have something to look for. Good. That narrows it down a little. If we're talking Medicare, we have to think about what they require that is different from other payers. Yes, Medicare also requires APC codes for every machine or procedure used to care for Medicare outpatients. So that's an additional code. I didn't look at that the other day, only the difference in volumes for all patients. So we would need to look at all Medicare outpatients who had a procedure and see if it includes the extra code. Medicare wouldn't pay unless both codes are provided. They probably only pay for the outpatient visit itself. That might even explain the differences we found between the injectable and infusible drug volumes from what they were actually using and the procedures. They weren't billing for the procedure, just the drug. Let's see if those codes are missing. If they're missing, we need to look at all undocumented drug administration procedures. It is definitely due to administrative errors. Apparently, the staff thought that if they were billing for an outpatient visit, that the injectable or infusible drug procedure would be covered by the APC code. They could have also overlooked the HCPCS code for the procedure. I guess the question is why that would start happening now. But thank goodness, that's not my problem. It will take me a little while to do the calculations, but yes, if the average loss for each undocumented procedure is around $100 or $125, that may explain the discrepancy between this year's revenue and usage compared to last year, specifically for Medicare outpatients. That is a huge majority of our patients. Yes, that's the short version. There are also volume discounts that would cause a further reduction in revenue. But that will take some research to give you in-depth figures. Yes, definitely. Tell her you will have the exact numbers by the end of the day on Thursday. I want to take some time to be sure we have this right. Hey, it's my job. Just wish I had thought of that angle a little bit earlier. Have a good night.
You know, I ran into Cheryl at the coffee shop and she spoke very highly of you. She said you were a good replacement for her. So I take it you solved our revenue problem. You know, I didn't want you to come back to me until it was solved. Okay, so what's the reason? So you were also right in that it's coding errors. How could this happen? Why would it start happening now? This is a new issue. We use software that automatically checks for any possible errors. Plus, we have claims reviewers spot checking 10% of the claims for our claims editing process. Obviously, that's not solving this kind of issue. At this loss rate, I could have hired 2 more full-time people. That's true. We usually do an extra training just to deal with Medicare and Medicaid requirements. It's possible some people miss that, although it is mandatory. So how do you think we should solve it? I was with you until you said cloud computing. I doubt that Medicare would approve that, or for that matter, if it would make it through HIPAA. It's just not secure enough. HIPAA is very strict about patient confidentiality, you know. Yes, true. That's why we haven't upgraded in 2 years. Oh, I like the way you think. Good job. I mean, I'm not agreeing to change all this right now. Obviously, we have to get on the claims issue right away. But I will take some time to think about it. Would you mind sending me what you found when you were researching? Thank you.
Oh, hi, how's it going? You must come here almost every day, too. I can't believe it, but I just ordered a double shot with my cappuccino and a piece of chocolate cake. I never do this. You should take more than cake, I think. You did a great job, I hear. Meredith filled me in earlier. And I'm sure you did learn a lot, even if it was stressful. That information will serve you well later. For example, you learned which stages of the revenue cycle are directly related to coding errors, right? Yes, and you know how coding relates to claim generation now. No, that's not really it. Right. And between your audit and your research, you should really understand how charge masters work. No, not really. Try again. Yes. And it sounds like you learned how important claims editing is. See? Now you deserve to relax. Enjoy your cake. I know I am. Anytime. See you soon.